Thank you very much. And thank you very much to the organisers for the invitation to be here. A fantastic lineup. And I'm going to expand a little bit on what Andy has been talking about for the last half an hour or so. My role in the clinic is as head of performance, which means I look after our residential athletes, usually elite athletes that come to spend blocks of rehabilitation time with us in Dublin. But I'm also heavily involved in our ACL and groin research programs, of which I just recently completed my PhD on the role of 3D biomechanics after ACL reconstruction. There are a number of benefits of working in the sports surgery clinic. Number one is you get a large volume of the same type of athlete. So as Andy said, we've almost 1,000 ACL reconstructions a year, mostly thanks to the man in the top right corner, who is Ray Moran, our Director of Medicine. He himself would do about 600 to 700 ACL reconstructions per year. But we have our biomechanics team, our radiology team, our strength and conditioning team. And so when you have a lot of different professions looking at the same problem, it really pulls you from your professional biases and begins to look at a more collaborative approach to trying to get a successful outcome. In our rehabilitation team, we are constantly sharing ideas and breaking down what we do and building it up to work out how can we best approach these athletes. What are the best tests to carry out? What are the best outcomes within those tests? And then how can we rehabilitate those athletes as efficiently as possible to achieve those outcomes? Because the number one question that we all get asked, either when you're pulling them off on the stretcher from the field or the first day after surgery, is when can I return to play? And we don't often get a lot of guidance from the literature. This review by Barbara Weston and I said that 40% of orthopedic papers had no return to play criteria, 32% had only had time from surgery, and 15% had time and subjective criteria. So it's been 7 months. How do you feel? I feel good. Okay, away you go and return to play. And 13% had objective criteria, although to be fair, the more modern literature is drifting more and more towards the requirement for objective criteria during this decision-making process. When we look about what kind of physical tests should be included, we know from the literature there are no tests or batteries currently that can predict when an athlete's ready to return to play. Although the suggestion is those tests should include some strength measures, some power measures, and an assessment of movement quality. The problem is what's good movement and what's bad movement? And what tests do we use then to try and assess the efficacy and efficiency of those movement patterns? However, limb symmetry is generally decided in terms of performance of strength and jump height and jump length as a good starting point to try and return with higher levels required for returning to more demanding pivoting sports. As many of the previous speakers will have alluded to earlier on, return to play rates can be mixed, 80% returning to some kind of sport, and there are a number of factors that are associated loosely enough with return to play. Improved hopping symmetry. If you're a younger athlete, if you're male, if you're elite sport, you're more likely to return to play. And if you have a positive psychological outlook. So do you feel you can return to play? No. Well, there's a good chance then that you won't return to play. So the athlete's attitude is also extremely important in that. But if we look at the main reasons for non-return, number one is cited as fear of re-injury. And some athletes will have an inherent anxiety about returning to play, not only in terms of the trauma towards the knee, because they're unsure if they're ready. So if that's is that the athlete's problem or is that my problem? Have I not outlined to them the requirements they're going to need to make in order to make a successful return? And have I not demonstrated them through their rehab and through their testing that they've achieved those outcomes? There are always social factors, works, contract, children, etc. But also there are a number who don't return because of ongoing anterior knee pain. And again, is that because of issues around the time of injury or the surgery? Or is it more due to I haven't sufficiently rehabilitated that athlete to allow them to perform pain-free sporting activities? And then there's the bridge between return to play and return to performance. Return to play is only a step towards returning to my best. There's a big difference between returning to my first game and returning to optimal performance post-ACL. Across most of the majority of American sports, you'll find, as outlined earlier on, about 80% return to play at the highest level, but often there is a reduction in performance compared to their peers. So how can we begin to bridge that gap? And even if we do make a successful return and return to the same level of participation, re-injury is a constant concern. We know that if you've had an ACL injury, you're 6 times more likely to have another one than a healthy athlete. We know the injury rate can be up to 30% for second ACL in the first 2 years, with the majority, twice as many contralateral injuries compared to ipsilateral injuries, especially in younger athletes. From our own registry data that's just been published in the American Journal of Sports Medicine, focusing only on level 1 athletes, that's athletes returning to pivoting sports, again an 86% return to play rate, 6% contralateral injury, 2.7% ipsilateral injury, only 1.3 for our patella tendons, and a higher, almost 7 times higher in our hamstring tendons. And interestingly enough, no relationship between time to return to play and re-injury. So after 6 months, there was no association between when you returned and your incidence of re-injury. So why is that, and what are the other factors that might influence that, apart from recovery time and graft healing? If we're looking to reduce ACL re-injury, we need to have an understanding of what are the factors that put us in that at-risk position. If I want to rehab someone, I want to think about what do I want to avoid, knowing that they're going into chaos. It's not possible to avoid chaos, but how can we begin to better make them robust? So ACL injuries very often when I'm absorbing load in single leg, I have a loss of that center of mass control relative to my stance leg, very often my foot externally rotated, and that associated valgus motion that comes as well. If we have a look at this video here, we can see such a subtle movement, but again, wide stance, big posterior ground reaction force causing anterior tibial translation, and pop goes the weasel. Also not very good tackling technique as well, but we won't say that to him today. However, it's important to realize that that anterior translation is the main way that the ACL is loaded, and valgus and rotation add to compound the injury. If you look at number 55, he's the guy that we're interested in here. If you look at him celebrating, I don't know what he's celebrating, but if you look at him celebrating, pop. So again, it's not like there's a single mechanism of ACL injury. As Andy pointed to earlier on, trying to pick one variable and saying that that's how you're going to get re-injured is a foolish approach, because it doesn't mean that that one variable will be able to predict, and there's many different ways of injuring your ACL on the field of play. So celebration is a risk factor for ACL injury. But it's not only avoiding re-rupture, it's also avoiding overuse injuries. We know that there's a higher risk after ACL reconstruction of other injuries to the knee, especially overuse injuries, whether that's to the patellar tendon, the patellofemoral joint as well. So we've a lot of work here to do to put back a robust athlete. So instead of asking ourselves the question, when is an athlete ready to return to play, maybe we should be asking, what does a fully rehabilitated athlete look like? When can I say that we've at least gone back to the level of physicality and function that we were before surgery? Knowing that that's never a fixed point. Every athlete can be stronger, can be faster, can be more explosive, can be more agile. But what is the base point at which I can say I'm happy that physically you've recovered from the initial injury and the trauma of the surgery that occurred afterwards? And can I write those tests and those variables down the day before surgery? And can I explain them to the athlete? And then can I use them as a constant reference point as I'm progressing the whole way through rehab? Or do I keep shifting and moving the goalposts as we get closer and closer to that 6-month part or that 9-month mark? So if we're looking to say what does a fully rehabilitated athlete look like, well, we'd ideally like to return to the same level of performance or higher, with no pain in my knee, to not re-injure either knee, knowing that the healthy knee has a higher risk of ACL injury. And ideally, if we achieve that, it would be nice to leave them back a better athlete than we found them before, given that almost half to 3/4 of these injuries are non-contact in nature to start with. So as Andy alluded to, in Dublin, we carry out a testing battery to try and create a profile of the athlete, decide where they are relative to what we believe the end should look like. And our research is trying to define which variables are most important for certain outcomes. So in our biomechanics lab, we have a testing protocol of counter-movement jumps for power, drop jumps for plyometric ability, hop for distance as is commonly used in the literature, planned and unplanned change direction, and then isokinetic testing obviously for those specific muscle deficits that are commonly found at the quadriceps and at the hamstring. So number one is, if we're trying to say we're going to go back to normal performance, we can use the healthy limb as normal, but that may not always be useful, or we can use uninjured athletes as a barrier for normal. So one of our colleagues, Chris Richter and Edwina O'Malley, looked just purely at isokinetic strength and counter-movement jumps to identify, could we predict at 6 months, were you normal or were you an ACL patient? Okay, had you done your ACL or had you not? All the data I will present is on male athletes. We're currently processing our female data, so you might want to bear that in mind. We looked at isokinetic quadriceps and hamstring strength at 60 degrees per second, and single leg counter movement jump in our 3D biomechanics lab. We want to know which measures and which variables could predict if you were uninjured or if you were post-ACL reconstruction. So we got some normative values. These are all field athletes, rugby, soccer, Gaelic sports, etc. For our quadriceps strength, we found on average that a jump height of 17 centimeters with mild asymmetry and strength up to 10%, but tended to be very symmetrical in their jump height. And we found that both the non-operated leg and the legs of the healthy athletes had a very distinctive pattern by which they generated power during the counter movement jump of 20% of the hip, 30% of the knee, and 47% of the ankle. And after ACL reconstruction, at 6 months, they no longer had this defined power. What ended up happening is they had a much larger hip power component as they began to use a hip strategy for compensating for the quad-specific deficits that were left afterwards. So what we found in this study was that with 90% accuracy, we could predict whether you were an ACL or a normal athlete, mainly through had you recovered your quadriceps strength specific to your body weight, the symmetry of that, what kind of hip strategy were you using during your counter movement jump, and your jump symmetry. So have I restored the sufficient amount of strength to the quadriceps group in particular during ACL rehab? But as we take things further forward, one of my first PhD studies was to look at our jump tests and not look only at the common variables of jump height and jump length, but look at the biomechanics of these jump tests. One of the first interesting outcomes we found was that not all jump values are the same. When we looked at these are athletes between limb differences at 9 months. And when we looked at the difference between limbs in a single leg drop jump, so that's where you're coming off a 20 centimeter step, a jump in a plyometric activity, there was a large effect size difference in jump height and poor return to play pass rate in comparison to the single leg hop for distance, which is commonly used, but has been shown again in more recent literature to be a poor outcome in relation to recovery post-ACL, as very often they can compensate. So when we're selecting our jump tests, it's important to realize that not all tests are the same, and because I get 90% or 100% symmetry in one, doesn't mean I'm achieving sufficient rehabilitation and outcomes. When we looked at the biomechanical differences across all 4 tests, we found a number of variables that were consistently asymmetrical. Number one is there was ongoing asymmetries in knee valgus moment, knee internal rotation angle, ankle rotation moment, and that makes sense, they're all coupled together, but also knee extension moment. And what we found when we compared the double leg and single leg tests, in the double leg tests, they tended to put greater ground reaction force through the non-operated leg. Obviously in the single leg test you can't do that, so they tended to bring their center of mass more forward to reduce the demand on the knee extensors. So the more I bring my center of mass forward, the less knee extensor moment I'm going to create during jumping and landing activities. So just a short video to try and illustrate that. If we look at the red arrows as he lands, his green leg is his operated leg. You'll see the much higher ground reaction force on the healthy red leg. Secondarily, if we look at the frontal plane, you see that during the point of landing, how the ground reaction force sits through or almost outside the knee joint, driving it inwards. So again, at 9 months, many of our ACL athletes are not restoring sufficient ability to absorb load vertically in the sagittal plane. Very important for controlling that anterior tibial translation, but also in the frontal plane. And they're deficits that we may need to address and target more during rehabilitation. However, 50% of ACL injuries occur during change of direction. So we looked then at our planned and unplanned change direction tests, doing a 5-meter sprint and cut, reacting to external lights for the unplanned cut. And we found that many of the biomechanical variables we found in the jump tests, or asymmetries, were also present in both planned and unplanned change direction. Asymmetries in the frontal plane, at the knee and the hip, and the ankle, sorry, and again, asymmetries at the knee joint in the sagittal plane. Reduced knee flexion, so change direction with a more extended knee, and as a result, more knee extension moment, reducing performance and maybe increasing ACL injury risk. But we're all inherently asymmetrical, so how much asymmetry is too much asymmetry? So we took these measures across our jump tests and change direction, and identified in what tests and what variables were our ACLs at 9 months more asymmetrical than healthy, uninjured athletes, male athletes, all playing field sports. Again, we found in the drop jumps, both double leg and single leg, there were deficits throughout the kinetic chain, as Andy highlighted again. Rather than focusing on any single variable, there were deficits throughout the kinetic chain, especially in vertical ground reaction force as well. And similar deficits were found during change direction tests. The interesting bit in both of these tests is that in change direction between limbs and in change direction asymmetry compared to normals, there was no difference in change direction time, the time to execute the movement, despite ongoing biomechanical differences. So again, change direction time seems to be a very poor outcome in assessing ongoing asymmetry post-ACL reconstruction, and therefore assessment of rehabilitation status. But many athletes are able to return to play, but often report ongoing knee effusion and knee swelling. So what we did then was had a look. This is unpublished data that's currently in review at 9 months. Those athletes that had returned to play and those that hadn't. But in those that had returned to play, about 1/3 said they reported some ongoing knee symptoms, and 2/3 said they were making a complete pain-free return to play. What were the strength and biomechanical differences between those that returned to play pain-free and those that didn't? We had a look at their quadriceps, hamstring, counter movement jump and drop jump strength tests, and we found again that there was greater weakness on the operated limb of the quadriceps and greater asymmetry of the single leg drop jump. So my quad strength and my plyometric ability was lower in those that reported ongoing knee symptoms than those that didn't, despite no difference in my counter movement jump and my hop for distance, but also no difference in my hamstring strength. Okay? Now it's a chicken and egg. Have I reduced quad strength because I'm sore, or am I sore because I have reduced quad strength? Either way, they're probably not meeting the thresholds of rehabilitation that we require. When we look at the odds of making a pain-free return to play, if I achieve over 90% symmetry of my quadriceps, I'm almost 3 times more likely. If I achieve greater than 90% of all these 4 tests, I'm almost 7 times more likely to make a pain-free return to play. So restoring quadriceps strength and plyometric ability is extremely important in restoring pain-free function. We're always judged on when can we return to play. What's the point in returning if I have ongoing knee symptoms? It doesn't make sense, especially as alluded to earlier on when we're talking about the long-term health of the knee. When we look at the biomechanical differences, there was no differences in the jump tests, but there were a number of differences in the change direction tests. If you look in the plan cut, when they knew that they were going to change left or change right, they reduced the force going through the knee. Lower vertical ground reaction forces and posterior ground reaction forces, and they slowed down before they cut left or right. In the unplanned cut, when they didn't know and couldn't prepare in time, again, they reduced knee extension moment, started to externally rotate their foot to compensate, and externally rotate their hip as well. So again, these are a number of strategies that we need to target during rehabilitation. The English speakers need a translation for my English, never mind for my French. And then we come to, too slowly, then we come to the most important one, everyone would argue, which is second ACL injury. The ability to predict not only injury to the limb that's been operated on, but also the contralateral limb. So again, we took male athletes. We prospectively collected data on 31 males that went on to re-rupture their operated limb, and 55 athletes that went on to rupture their previously healthy or unoperated limb. And again, we went through the test battery as outlined of strength, jump, and biomechanical performance tests. I want to know the difference on the operated side and in symmetry between groups. When we looked at those that went on to injure their healthy limb, at their operated limb, at 9 months, we found no differences in any of the commonly used performance tests. No difference in their quadriceps strength, no difference in their hamstring strength, no difference in their jump height, either for a counter movement jump or a drop jump. That doesn't mean that those variables are not important. It's important that we restore normal levels to get normal optimal performance. We've seen the differences in those that have pain and those that don't have pain, but it seems like there's no difference when you test them at 9 months in using these tests to identify those who will go on to suffer re-rupture. What we did find, despite no difference in performance measures, was some biomechanical differences. When looking and comparing only the the injured leg, we found that in the double leg drop jump, they tended to collapse more. So their center of mass fell more towards their knee and towards their ankle. They had greater knee flexion and longer ground contact times. So in other words, they spent longer on the ground and collapsed more. They had difference in the ability to absorb load in the sagittal plane. When we look at asymmetry, they had greater asymmetries in the frontal plane primarily during change direction. Greater asymmetry in trunk side flexion, in the distance from my center of mass to my knee, and in pelvic tilt and in pelvic drop. Now these variables were unable to predict who would go on to second injury. In one way that makes sense, because in my healthy limb there's many factors that are included, or in my operated limb, that influence my injury, such as my graft selection, my surgeon choice, time of healing, etc., etc. However, these may be variables that we need to be targeting as they relate to commonly seen mechanisms of injury and the need to rehabilitate not only the knee joint, but focus throughout the kinetic chain in both jump and change direction maneuvers. When we come to the healthy limb, and we looked at those who went on to rupture their healthy limb and those that didn't, we did find a small difference in quadricep strength between those that did and those that didn't. But no difference in hamstring strength, counter movement jump, and drop jump, either on the healthy limb or in symmetry, which kind of rubbished one of my initial hypotheses, or our hypothesis would be that we haven't done a sufficient job of rehabilitating the operated leg. More of that load or stress goes on to the healthy limb, and therefore it increases its susceptibility to ACL injury. However, these tests didn't notice any difference at 9 months between those who went on to injure their healthy limb and those that didn't. There were no difference in change direction variables and no difference in biomechanical asymmetry, which again we found very interesting. However, what was most interesting was there was large differences in the plyometric activities during the double leg drop jump and during the single leg drop jump. Those that went on to injure their previously healthy limb were less plyometric, less stiff in the vertical plane. They had longer ground contact times, lower center of mass stiffness, greater collapse of the center of mass relative to their knee and ankle. And as a result, they flexed more and had lower moments throughout the kinetic chain. So again, valgus has tended to be a focus throughout the literature, mainly because much of our research tends to be prospectively on female athletes because they have much higher incidence. But in male athletes, those who have had ACL reconstruction, there was marked differences in that vertical stiffness, that ability to control anterior tibial translation or sagittal absorbing of load in those that went on to re-injure and those that didn't. And that may be something that we need to focus and target on during our rehabilitation. You'll see all the variables there. Reduced stiffness and therefore more flexion throughout compared to those that didn't re-rupture. If you can see that illustrated here, again, if you watch the sagittal plane, trunk flexion, knee flexion, and then that struggle controlling anterior tibial translation of the femur. And again, we focus a lot on the quadricep, we focus a lot on the hip, but how much is our ankle stiffness really important in controlling that anterior tibial translation, especially during dynamic movements where we're absorbing and reloading again. And then we have return to performance. And so there are a number of outstanding speakers that will present throughout the rest of the afternoon, and they will try and fill the gap between the lab and the field. If we look at Quade Cooper up here, he plays rugby union. Much of the game will happen in front of him, throwing the ball, kicking the ball, tackling. He will cover about 6 kilometers in a game. You've Daniel Menzel. He has had 4 ACL reconstructions, playing AFL. His game is pure chaos, high catching, tackling, fielding, kicking. He will cover somewhere between 14 and 16 kilometers per game. You've Robert Griffin III, #1 draft pick, ruptured his ACL in his first season and re-injured in his second season. He will have to throw the ball is the main skill he will have while trying not to get killed by guys that are much bigger than him. He will run around for 4 or 5 seconds. He will do that 8 to 10 times, and then he will sit down for half an hour. So the levels of conditioning needed for each of these athletes are very, very different. And if we're going to resist fatigue, as Andy highlighted earlier on, they're going to have different conditioning levels even though they're all the same athletes. They've all the same injury. If they're going back into very different environments, the skill acquisition and the chaos that they're going to be exposed to will be very, very different. But underpinning it all, I would argue the levels of strength, the levels of power, plyometric ability, and mechanics during change direction and during landing are the basement on which you'll build everything else that comes afterwards. And the exciting part for our job is how can we find new and innovative ways to try and rehabilitate our athletes as efficiently as possible to prepare them to bridge the gap between the lab and the field. And as Andy alluded to earlier on, trying to take some of those biomechanical tests and bring them all to a field-based setting and expanding our knowledge from there. So, we all rehabilitate ACL injuries here. That's part of the reason that we're at this conference. But if we were all tomorrow morning to write down what does a fully rehabilitated athlete look like, would we all have a degree of consistency between us? What variables would we write down and tests would we use to say, can we return you to the same level of play of higher, with no pain, to not re-injure, and to leave you as a better athlete? If I can't write that down before surgery, how am I going to have the most effective outcome? How can I write a program when I don't know what I'm aiming for? If I focused only on one variable, one test, be that strength or power or plyometric, or focus only on knee valgus, am I missing the combination of factors that influence all these outcomes together, thus optimizing the recovery and outcome? Because I can return to play with ongoing knee pain, or I can return to play and re-injure, or never return to play, and what's the point? Thank you very much.